Good morning, one and all. I'm Dr. Sneha Shanbag, internal medicine specialist. I'll be talking on the topic Code Blue. Demonstration will be done by Nurse Clevita and Nurse Ayman. I'll be discussing this topic under the following headings: sudden cardiac arrest, introduction to resuscitation, basic life support, and advanced cardiac life support. Sudden cardiac arrest refers to sudden cessation of cardiac activity with hemodynamic collapse. Sudden cardiac deaths account to 15% mortality in industrialized countries. Most common cause is known to be ventricular fibrillation and ventricular tachycardia, generally in the presence of underlying structural heart disease. Risk factors are similar to coronary artery disease like cigarette smoking, alcohol, sedentary lifestyle, etc. Approximately 450,000 individuals suffer out of hospital sudden cardiac arrest in United States. Roughly half of these patients have resuscitation attempted by the emergency services. Despite development of cardiopulmonary resuscitation, defibrillation, and other advanced resuscitative techniques over the last 50 years, survival rates remain low. Effective delivery of BLS interventions is strongly and consistently linked to improved survival and favorable recovery after sudden cardiac arrest. Introduction. The field of resuscitation has advanced over more than 2 centuries. Paris Academy of Science recommended mouth-to-mouth ventilation for drowning victims in 1740. In 1891, Dr. Frederick Maas performed the first documented chest compressions. The American Heart Association formally endorsed cardiopulmonary resuscitation in 1963, and by 1966 they had adopted standard guidelines. The AHA and European Resuscitation Council developed the most recent ACLS guidelines in 2020 and 2021. Code Blue. Code Blue deals with the measures taken to assist a patient who has sustained a cardiopulmonary arrest in a hospital setting. This Code Blue has got two parts. The first part is the basic life support and then the advanced cardiac life support. So basic life support consists of prompt recognition of cardiac arrest, activation of emergency response system, immediate delivery of high quality CPR, and when available defibrillation using an automated external defibrillator. Key concepts of basic life support: check scene safety, check patient arousal, check carotid pulse for 10 seconds, call for help and start chest compressions, activate Code Blue, and use an automated external defibrillator and operate according to the prompts. First is as soon as a patient undergoes a sudden cardiac arrest, his heart goes through 3 phases: the electric phase, the hemodynamic phase, and then the metabolic phase. Electric phase is the first 4 to 5 minutes after the heart stops. Ventricular fibrillation may be successfully reversed with defibrillation. In case immediate decompression is unavailable, chest compressions can be continued at this time. Then comes the next 4 to 10 minutes following the sudden cardiac arrest. Coarse ventricular fibrillation now turns to fine ventricular fibrillation and then asystole. So if you continue chest compressions, they can improve myocardial oxygenation and can halt this progression. Metabolic phase is when the patient has a cardiac arrest for more than 10 minutes. It depends on all post-resuscitative measures like thermal therapy, but if it's not quickly converted into a perfusing rhythm, most patients don't survive this stage. Points to remember: excellent chest compressions, ventilations, that is 30 compressions to 2 rescue breaths, and defibrillation, early defibrillation in ventricular fibrillation and ventricular tachycardia, 200 joules in biphasic defibrillators and 360 joules in monophasic defibrillator. Now we go through the algorithm for adult cardiac life support, the basic life support. So we first verify scene safety, check for responsiveness by tapping the patient's shoulder, call for help, activate emergency response, get an AED. What is check responsiveness is we look for no breathing, whether the patient is breathing and whether he has a pulse. If he has no normal breathing but pulse is felt, we continue to monitor the patient and we provide rescue breathing. If there is normal breathing and pulse is felt, we continue to monitor till the emergency response arrives. If there is no breathing and no pulse, we start CPR. We perform 30 compressions and 2 breaths and use an AED. AED arrives, we check the rhythm. Shockable rhythm, we shock the patient. Unshockable rhythm, we continue CPR. Adult cardiac life support, the principles are excellent. First is excellent basic life support. So again we talk about excellent chest compressions, which are of chest compressions which should be of sufficient depth, that is 5 to 6 centimeters or 2 to 2.5 inches, and rate between 100 to 120 per minute. The mantra we follow for chest compressions is push hard and push fast, around 100 to 120 compressions in 1 minute. Then one single biphasic defibrillation shock remains the recommended treatment for ventricular fibrillation or pulseless VT, and delivery of 30 compressions followed by 2 rescue breaths. Resuscitation team management. The primary goal of crisis resource management is to access the collective knowledge and experience of the team in order to provide the best care possible and to compensate for oversights or other challenges that any individual is likely to experience during such stressful event. The two principles are leadership and communication. So one person assumes the role of a team leader, and this person is responsible for global management of resuscitation, including ensuring that all required tasks are carried out competently. Communication is organized to provide effective and efficient care. Specific emphasis is placed on assigned team member repeating back medication doses and defibrillator settings. Initial management is circulation, then airway, and then breathing. Once unresponsiveness is recognized, resuscitation begins by addressing circulation, followed by airway opening and then rescue breathing. The ACLS guidelines emphasize the importance of excellent uninterrupted chest compressions and early defibrillation. In non-cardiac arrest situation, the other initial interventions of ACLS include administering oxygen, establishing vascular access, and placing the patient on a cardiac and oxygen monitor. In the minutes following cardiac arrest, oxygen delivery is limited primarily by reduced blood flow, leading to recommendation that excellent chest compression take priority over ventilation. ACLS guidelines support the use of bag valve mask device or placement of a supraglottic airway. The compression to ventilation ratio has to be 30:2. The three medications that we could be using during CPR are epinephrine, atropine, and amiodarone. The commonest drug used is epinephrine. It's a sympathomimetic drug, acts on alpha 1, alpha 2, beta 1, and beta 2 receptors. During CPR, we check for perfusing or non-perfusing rhythm. If the rhythm is non-perfusing, we go ahead with epinephrine. If the rhythm is perfusing, we first do defibrillation. Then we think about after 2 shocks, we can give epinephrine. Atropine is only for bradyarrhythmias, and it's not recommended in any other asystole or pulseless electrical activity. Amiodarone is the third line of treatment after the VT is revived, but the VT continues. Pulseless VT and VF are non-perfusing rhythms arising from the ventricles, and the only correct treatment for this would be continuing CPR and giving epinephrine. Continuing CPR and defibrillating. Asystole and pulseless electrical activity are non-perfusing rhythms, and for these once identified, we have to go ahead with CPR and injection epinephrine. When do we terminate CPR? Duration of resuscitative effort is more than 30 minutes without a sustained perfusing rhythm. Unwitnessed collapse, prolonged interval between collapse and initiation of CPR, patient's age, severe comorbid disease, and prior functional dependence. Best predictor of outcome may be the end tidal carbon dioxide level following 20 minutes of resuscitation. We go quickly through the algorithm. So we identify cardiac arrest, and ACLS protocol has been started. We start with the CPR. We check the rhythm. If the rhythm is shockable like VF-VT, we give the shock. We continue CPR for 2 minutes. IV and IO access is started. Again, we check the rhythm. If the rhythm is shockable, we go ahead again with the second shock. We keep the injection epinephrine ready and we give it at 3 minutes after the second shock. We continue CPR, we check the rhythm. Rhythm is shockable, we go ahead with another shock. If the rhythm is non-shockable, that is, it is either asystole or pulseless electrical activity, we give injection epinephrine and then we continue CPR. Now we will demonstrate how to perform excellent CPR.
Okay, we have our nurse Ayman. He is going to demonstrate how to perform excellent chest compressions. So he has placed one palm on top of the other, interlocked his fingers, and now he's keeping it on the lower third of the patient's sternum. The elbow straight and the whole body bent on the patient's chest, and the pressure comes from the shoulders downwards. Now we go hard and fast, and we wait for the chest to recoil in every compression. Now Mr. Ayman will start his compressions.
Okay. 1 2 3 4 5 6 7 8 9 10 11 12 15 16 17 18 19 20 21 22 23 24 25 26 27 28 29 30 31 32 33 34 35 36 37 38 39 40 41 42 43 44 45 46 47 48 49 50 51 52 53 54 55 56 57 58 59 60 61 62 63 64 65 66 67 68 69 70 71 72 73 74 75 76 77 78 79 80 81 82 83 84 85 86 87 88 89 90 91 92 93 94 95 96 97 98 99 100 101 102 103 104 105 106 107 108 109 110 111 112 113 114 115 116 117 118 119 120 121 122 123 124 125 126 127 128 129 130 131 132 133 134 135 136 137 138 139 140 141 142 143 144 145 146 147 148 149 150 151 152 153 154 155 156 157 158 159 160 161 162 163 164 165 166 167 168 169 170 171 172 173 174 175 176 1
We have given 30 compressions. Generally, we give around 100 to 120 compressions in 1 minute. We push hard and fast. After every 30 compressions, we do ventilation. Now we will demonstrate how to do excellent bag valve mask ventilation by our nurse, Ms. Clevita. So you can see the Ombu bag with the mouthpiece. Now she has encircled her first 2 fingers in a C position on the mask. Now she will place this mask on the patient's nose and mouth. The other 3 fingers will go under his jaw and she'll lift the jaw up. So this opens the patient's airway. Now she will count only 2 ventilations after the 30 compressions. 1, 2. So this way we have given 2 rescue breaths after the 30 compressions. Generally we give around 6 to 8 breaths in 1 minute. Thank you.
These are my references. Thank you so much for your